Okay, so I'm going to be explaining my Simple Minds for Gestational Diabetes for week 4. So first I'm going to do the diagnosis. So the definition. Gestational diabetes is basically an impaired tolerance to glucose, with the first onset occurring during pregnancy. It usually occurs around 24 weeks of pregnancy, and it's when the normal range of blood glucose is out of or the range of blood glucose is out of the normal range. So the normal range during pregnancy should be between 70 and 110. So gestational diabetes would be if it is out of that range. And there's two groups, which include pre-gestational diabetes and then gestational diabetes. So some risk factors. So risk factors include obviously pregnancy, obesity, hypertension, glycosuria, which is an excess sugar in the urine, a maternal age older than 25, family history of diabetes, and a previous birth of a large baby or a stillborn baby. Some signs and symptoms, so it depends on which type of diabetes mom has. So if she has hypoglycemia, she will have symptoms such as nervousness, headache, weakness, hunger. She'll be irritable, and she may have tingling in her extremities or her mouth and some blurred vision. If she's hyperglycemic, she'll have polydipsia, which we know is increased thirst, polyphagia, which we know is increased hunger, and polyuria, which we know is increased in urination. She might feel nauseous, she might have some abdominal pain, and she will have a fruity odor to her breath, and flushed, dry skin. And these symptoms typically disappear a few weeks after delivering the baby. Some complications that can occur if gestational diabetes is diagnosed, it would be developing type 2 diabetes for moms. So approximately 50% of women develop type 2 diabetes within 5 years of being diagnosed with gestational diabetes. It also increases risks to the fetus, so that would be spontaneous abortion, different types of infection, so that would be urinary or vaginal, and that's due to the increased glucose in the urine. Hydroamniosis, which we know is an excess of amniotic fluid, ketone acidosis, hypoglycemia, and hyperglycemia for the baby, and with hyperglycemia, that can actually cause an excess fetal growth, which can be harmful as well. And the spontaneous abortion can be due to the poor sugar control for mom. Some diagnostic testings that we have here, which are very important. We have the routine urinalysis, and then we have the 1-hour glucose tolerance test. So that's where mom is given 50 grams of an oral glucose, and then we test her blood sugar 1 hour later. And that's performed at 24 to 28 weeks of pregnancy. Now, if this test is positive, that would be a blood glucose of 130 to 140 or greater. We would then have her do the additional testing, which would be the 3-hour oral glucose tolerance test. So the oral glucose tolerance test is followed by an overnight fasting for mom, so no caffeine, no smoking, and no other foods, 12 hours prior to the test. Once the glucose level is obtained, then a 100-gram glucose load is given, and then we recheck the glucose levels for mom at 1 hour, 2 hours, and 3 hours following the 100 gram of glucose being given. And the results of that test, if still elevated, would give us a diagnosis of gestational diabetes at that time. Some other testing would be the presence of ketones in the urine, the biophysical profile, so that would tell us the fetal well-being, an amniocentesis with the alpha-fetoprotein, and the non-stress test that would also give us an idea of the fetal well-being. So as far as the incidence, inside the U.S., there was a study done in 2018 that noticed that in the U.S. alone, the incidence of type 2 diabetes and gestational diabetes has increased by 11% and 9%. And I actually found that in the ATI book, it stated that as well, that the gestational diabetes is increasing in the United States. In this article specifically, they had 450 moms, and 10.4 reported one diagnosis of gestational diabetes during pregnancy, starting at an average of 30 years old. And then 3.1% reported getting type 2 diabetes as a result of the gestational diabetes later on in life. Then we have outside the US, where I looked at another article that looked at the prevalence in other countries and between different races. So it examined expecting mothers who had scored highly on the oral glucose tolerance test. They found that there is little information connecting maternal country of birth and gestational diabetes. However, there was an increased risk among Blacks, Asian Indians, Filipinos, Pacific Islanders, Chinese, and Mexicans. And they noticed a decreased risk in Japanese and Korean women. So then for my nursing diagnosis, I gave two. So the first one is ineffective health maintenance related to gestational diabetes as evidenced by knowledge deficit. So our goals for this mom would be to demonstrate increased knowledge about the condition, to know some prevention tips and healthy eating habits, and have mom be able to demonstrate the proper way to monitor her blood glucose and administer her medications if that's indicated. And then the second nursing diagnosis would be anxiety related to threat to fetus, as evidenced by questions regarding conditions' effect on the fetus. So if mom is nervous that gestational diabetes is going to harm her or harm her unborn baby. So some goals for this mom would be routine exams, adequate teaching, explaining the negative effects that this could have on mom or baby and ways that she can control them, setting realistic outcomes, and positive reinforcement for our healthy behaviors. So then the physiology and pathophysiology, so the mechanism of action. So obviously gestational diabetes is a lot like regular diabetes in the case where it involves the pancreas, the liver, the muscles, the adipose tissue, the GI tract, the brain, and the kidneys. Key factors include the existence of pancreatic beta cell dysfunction and the unmasking of the problem by development of insulin resistance during pregnancy. So when mom is pregnant, she obviously has a lot of hormonal imbalances and other changes that her body goes through. So this can be one of them. The deficiency of mom's resistance to insulin impacts the body's ability to obtain essential nutrients for fuel and storage, and most importantly, for fetal development. And it also does change during the different stages of pregnancy, so it's important to monitor this very closely at all stages of pregnancy. Some treatment obviously would depend on the level of diabetes diagnosed. Most include fetal surveillance frequently, diet and exercise. Diet is usually the biggest and best treatment we can do. We don't want to move on to medications if diet and exercise can control the diabetes. And of course, exercise would be encouraged and prescribed by the primary care provider. We don't want to have her, working out like crazy. Just some regular exercise, and then if necessary, insulin therapy or oral therapy. So some medications would be if diet and exercise is not enough. We want to start with oral medications. That's typically easier to manage for mom rather than having to check her blood sugar and give herself an injection every day. So some of the most common used during pregnancy are glyburide and metformin. And then if that doesn't work, we would go to insulins. Some safe insulins noted are short-acting Humalog or Novolog, as those are known to not cross the placenta. And then finally, some nursing interventions. So some basic assessment that we would do on mom is a detailed history and physical at each visit, especially during that first prenatal visit. We want to get the most information we can. We want to monitor blood glucose closely. We want to identify different risk factors in new moms. We want to monitor the fetus closely, and we want to really obtain a good family history. And then education. So we can teach mom about daily kick counts to monitor baby, teach the importance of healthy diet, and really it would be good to consult with a registered dietitian, have mom meet with them regularly. We want to encourage exercise during pregnancy and explain what safe exercises include and which are not safe. We want to encourage medication management, if necessary, insulin self-administration, and blood glucose monitoring, when to do so, when to administer the insulin, how to administer the insulin, when to check your blood sugar levels, when to be concerned, when to call us, and what's normal limits. We also want to explain that we will need some postpartum care and blood tests to ensure that mom and baby are healthy and that mom's levels are returning to normal. and that this did not affect the baby negatively. And then we also want to explain the risk of developing type 2 diabetes in the future for mom, and what she can do to hopefully decrease that risk. And that is gestational diabetes.